Hi, I'm Dr. Thomas Hirsch, inventor of the Isolite and co-founder of Zyris Inc. Today what I'd like to talk to you about is our new anterior mouthpiece that you're going to be receiving and utilizing today. As we all know, changing our behavior is a difficult thing to do, so whenever we have a new product and we have new behavioral changes, it's always a little interesting to try and introduce it into the practice. But I think you will find this to be a very nice product that will help you do your anterior work, keep the lips up and out of the way, and evacuate all the fluid and keep the throat dry and protected. So I'm going to show you the mouthpiece, talk about its properties and how to place this in the mouth and what we're going to do. So first of all, we have our anterior mouthpiece. It will come pre-packaged just like this. It has an opening perforation on the side, so when you open this up, just grab it here, tear it down. You've got easy opening. Pull it right out of the package, and here we have it. So the first thing that you're going to notice about this is it is bilaterally symmetrical. The top looks like the bottom, the right looks like the left. It's close to being bilaterally symmetrical. The top is actually shaped a little differently than the bottom is, and we can tell what the top is because it says TOP right here on the top. We have the lip retractors, which keep the lip up and out of the way. It's very soft, it's very flexible. It's the same durometer as the Isolite, meaning it has the same softness as the Isolite, so it won't injure the soft, delicate oral tissue. On the sides, we have a bite block right here that the patient can rest their jaw on. You will also notice the upper flange right here is protecting them from going down the throat, and the lower flange right here protects the tongue and keeps the tongue out of the way and out of your business. So when we put this in the mouth, the first thing that we want to do is have the patients lick her lips. And the next thing we want to do is spray water on the back side of this mouthpiece. So I'm going to reach up and grab my three-way syringe, fold this over, and just a quick little spritz. That's all we have to do. The patient will normally have Vaseline applied to her mouth. I'm just going to have her lick her lips right now, get them nice and moist. And you can see I've pinched this together gently. I'm going to put my index finger right here. I'm going to slide this into the right cheek area, just like this. And it pops in very nicely and very gently. Have her close down and rest on that. And you can let's straighten this out just a bit. There we go. Bite down. And you can see the amount of retraction that we have in the lower arch and on the upper arch. Close down a little bit for me. Sometimes we use our finger to raise this up a bit. Sometimes we may pull our finger to lower that down a bit. As you can see, the throat is totally protected and obturated, and on the lower arch, as you can see, the tongue is up and out of the way. So any procedures that I would be doing with the handpiece, any class 5 procedures from bicuspid, anteriorly, all the way around to opposite bi on the other side. Same thing for the maxillary arch. Any class 5 procedures, lip is up and out of the way, and water is constantly being vacuumed. Any class 3 procedures from the lingual aspect, we have great access. We have room for our mouth mirror, and we have room to prepare everything working directly or indirectly looking in the mirror. If we want to do any lingual mandibular procedures, we can do that also, although we know there are very few times that we ever have to do that. But what you might want to do is 3-to-3 bonding right here. If you're placing any orthodontic bonding, any orthodontic lingual wires, you can bond from 3 to 3, and the tongue's out of the way and everything's kept dry. She can open wide for us, lips stay out of the way. She can close down, lips stay out of the way. We have great control of the oral environment. There. Now, we can connect the saliva ejector one of two ways. Either one, while it is in her mouth, or two, when it's out of her mouth. Demonstrating it the first way, I'll just take the saliva ejector, and I'll put my 180-degree bend in it. And this just plugs right in to the saliva ejector port right here. Open just a bit. Plugs right in. Bite down, and we're good to go. So wherever I'm squirting the water is being vacuumed. If the saliva ejector was in my way on the right-hand side, just take it out, move it around, put it right over there on the left-hand side. Once that saliva ejector is wet, it goes in really easy. So when you're finished with the procedure, I'm going to show you how to remove the mouth. You can just have her close down. Pull everything right out of her mouth. Just pull it right out, just like that. And we're finished with that procedure. And so since we are a single-use item, just disconnect your saliva ejector, take this, and just chuck it right in the trash. So, thank you very much for your time and attention. I hope that you find this mouthpiece to be as beneficial and useful to you as I have found it for my own practice. Thanks a lot, and good luck with this.